And
We're
you'll just
going
be
live.
quiet for a minute, Dr. Karbakhsch, as we do the introductions. Thank you.
We are live and recording.
Thank you, Valerie. Sorry, we were a little slow getting the webinar up and running this morning. I know you're used to us getting in a little earlier than that. We've got over 1,100 people signed up for today's webinar, so we were just tweaking some settings on our end. If you were looking for the WAGD Stay Home, Stay Healthy CE series, you are in the right place. You're going to see some flyers going by with QR codes. These QR codes will allow you to sign up for upcoming webinars. We don't have a lot listed right now. We are going to finalize next week's CE webinar events here probably by the end of the day. Those will be up on Facebook on our website, and you'll be able to register probably starting Saturday morning. You'll see a lot of the webinars that are going by have already occurred this week. We had a great week of webinars so far. We have done, I think, 12 webinars. Had just a great lineup on Monday, sponsored by the International Academy of Nathology. On Tuesday, the Arkansas Academy of General Dentistry were our co-sponsors. And yesterday was Card P Day, sponsored by the Canadian Academy of Restorative Dentistry and Prosthodontics. Thank you to those organizations for supporting us so well and helping to put webinars together. If you missed a webinar and would like to see it, go to YouTube. You can go to Washington Academy of General Dentistry. The webinars are there. For instance, Dr. Karbakhsch's webinar will be up on that site probably within the next 3 or 4 hours after the webinar is completed. We will transcode it and put it up there. Unfortunately, we cannot give you CE credit for watching something on YouTube. We'd like to thank our sponsors for today. Our sponsors are the University of Washington School of Dentistry CE Department. You will be receiving your CE credits from the University of Washington School of Dentistry CE Department. They are not coming from the Washington Academy of General Dentistry. Please do not contact us regarding CE questions. When you get that CE, it'll be in PDF format. It's not personalized for you. Just put your name on there, save that in a file, just in case you need that documentation later on. And that, again, is coming from the University of Washington School of Dentistry CE Department. If you don't see that in a few days, check your spam filter, check your junk email. We'd like to thank the Seattle-King County Dental Society, Snohomish County Dental Society, Pierce County Dental Society, Patterson Dental, Comet USA, and Canadian Academy of Restorative Dentistry and Prosthodontics for being our sponsors. If you want to sign up for next week's webinars, again, within a couple of days here, we'll have those all on our website. That's washingtonagd.org. The QR code is right there for you if you need to navigate to it. We have been putting these webinars on for the past couple of weeks. This is the WAGD Stay Home, Stay Healthy CE series. Thank you for everybody that has attended. We've had over 22,000 unique individuals on these webinars, so hugely successful. And next week, for those of you that have not done your opioid or suicide training, we are going to have on Monday opioid and suicide training. That will be at www.washingtonagd.org. You can probably look for that information, the registration to be on there Saturday morning. Right now, we don't know for sure. We have a limit on 3,000 that we can have attend that webinar on Monday. We're looking for some support from our other sponsors to help put that together and help with the honorariums. If we don't get as much sponsorship from our supporting co-sponsors, then we're going to have to limit that to AGD members only. I'm sorry about that. So it's just financially what will have to happen if we don't get a little bit more support here before Saturday. So we'll do our best, see what we can do, but be looking to register for that. And that's the opioid training and suicide training. That will be fulfilling your requirement for Washington State. So, well, we're way behind here this morning. I apologize for that. Dr. Karbakhsch, I am going to stop sharing my screen, and I am going to let you share your screen. And as you're doing that, I'm going to read your bio. Dr. Minou Karbakhsch completed her dental education in Göttingen, Germany, where she practiced general dentistry and was an assistant professor at the Medical University in Hanover, Germany, where she also completed her doctoral dissertation. Dr. Karbakhsch completed the postdoctoral program in periodontics and implants at the University of Washington in Seattle. In addition, she also completed a one-year implant prosthetic residency with special emphasis on anterior implant restorations and aesthetics at the graduate prosthodontics department at the same university. Upon completion of her training, Dr. Karbakhsch taught at the University of Washington. She has been in private periodontal practice since 1999 with her current office locations in Tacoma and Kirkland. Dr. Karbakhsch, welcome. I'm sorry we had a little bit of a hiccup here before we got rolling this morning. Can you hear us okay?
Thank you. Yes, I do. A little bit soft, but I am very happy that I am connected. And I wouldn't be able to manage this without your wonderful help. So thank you very much for connecting me properly. I believe I had too many monitors. And I thought I'm going with the time. Clearly not.
All right. I just want to let everybody know with your Zoom interface, you have a chat feature. The chat feature is used for just little comments, etc. That is not for questions. If you have questions for Dr. Karbakhsch today, put those in the Q&A tab. Okay, so play around with your interface. You can change the speaker view. You can change from speaker for gallery. You can exit full screen. You can bring up those chat windows. We are not using the raise the hand feature today either, unless Dr. Karbakhsch asks you a question directly and wants a show of hands. So just lower your hands if your hands are up. But again, play with that interface because Dr. Hayamoto will be putting a lot of information over into that chat side on the right-hand side. And you get to that again by exiting from full screen, clicking on your chat feature. Thank you, Dr. Karbakhsch. I'm going to mute myself.
Thank you very much, Dr. Hess and Valerie and Dr. Hayamoto. Good morning, everybody. And I must tell you, it is a very odd feeling to be speaking to two monitors. If I was a psychologist or a psychiatrist, I would diagnose myself with something significantly wrong. So weird feeling not to be seeing you and not to be able to gauge your reactions. Welcome. And I'm very, very excited. And I'm also a little bit nervous about what we are going through right now and sharing all of that with you. Today's topic, COVID-19 getting ready for practice, evolving systems. Why? Dispelling fear through transparency and education. Or, as Winston Churchill said, never waste a good crisis. I will start this presentation by making my first disclaimers. 1, I am German. 2, I am also Persian. 3, I grew up in Iran for 11 years before the revolution. and went to a French Catholic missionary school. 4, I lived in Germany, France, Switzerland, and now in the United States. 5, I'm a periodontist. 6, I may be talking too much once in a while. 7, I will introduce you to my classmates with whom I had an absolutely wonderful experience and learnings at the University of Washington. My dear friend and classmate, Dr. Michael Zibbets, England, South Africa. I am in the middle, again, a hybrid. Dr. David Baker, California transplant to Washington. And my dear friend Ken Akimoto, who is Japanese with American English roots as well. So, final disclaimer is German is my first language, French is my second language, Farsi is my third language, English is my fourth language. I lived in many countries. I have many international friends, and I would like you to bear with me and not to focus on the on the words, as I will be constantly on the search for the perfect word, the perfect sense, and I might have some fillers in between. So if I switch to a language that you don't understand, I'm sure Dr. Hess is gonna tell me that I took off in a different language. I hope that won't happen. I will share with you a little bit about my background. As Dr. Hess nicely said, I started to study medicine and added dentistry in the mid-80s in a beautiful city with the name of Göttingen. Congratulations, Dr. Hess, you did a fantastic job actually in pronouncing that. You only butchered my last name. Göttingen is very famous for a goose or a Geesliesel. This is an old academic tradition in an old university town. This lady and this statue is known as the most kissed woman in the world. And since this is over 500 years old, and the tradition is that everybody that gets a doctorate at the University of Göttingen has to climb up on this little water fountain, which is more slippery than not, has to give her a bouquet of flower and kiss her. We can see that in the time of COVID, the Gänseliesel got with the program too. I practiced dentistry and I finished my PhD at the University in Hanover and moved to Seattle once I got accepted in the perio program, which opened up an unbelievable world for me, an unbelievable world of learning, of culture, of kindness, of challenge, of hard times. I was fortunate enough to have the opportunity to work with wonderful mentors. Dr. Cheryl Townsend, Dr. Cohen Gottlieb, Dr. Cohen and Gottlieb, Michael Cohen and Gottlieb, and then I settled in the Seattle-Tacoma area. Just recently, it feels like years ago, but it was just 2 months ago, I was traveling to Germany. It was at the height of the carnival. My dear friend and colleague, Dr. Margaret Baumer, who is also a graduate of the University of Washington, we have a continuous education institute in Cologne. And we were putting on one of our hands-on courses. Unbeknownst to us, there was an uninvited guest at that point in Germany with the name of COVID. And it spread quite fast during the time of the carnival, because we all know Germans party. For the record, this is water. I would like you to look at this. This is a setup that we have routinely, that we have and we had routinely before we knew about COVID-19, about Corona, the virus, and not the beer, and about our routine procedures and performances in the dental office. These are wonderful friends and colleagues, absolutely outstanding dentists that come to the clinic and perform the surgeries that we have planned for. We'll get back to that later. So what happened? I came back March 1st, and 3 weeks, not even 3 weeks later, we are in a complete lockdown. The world stopped. The world came to an end. We did not know what happened. Just 2.5 weeks ago, I heard about the virus. I did not even know it existed, literally, and I thought China is so far away. We went from a very busy and very involved practice to feeling like this little
And KFC.
I'm not sure if the audio comes through.
Chinese is close too.
Yes, it does.
What deliveries?
All the deliveries. You've literally got to eat mummy's cooking now. I'm sorry. I'm so sorry. I'm so sorry. Pizza Hut's closed too.
Every time I see this, I have to chuckle. The little girl whose world came to an end from one moment to the other, from one day to the other. All of her favorite fast food restaurants came to a lockdown. There was none of her joy, none of her routine, nothing that she knew left. I sure can relate to this little lady. And it is funnier when it happens to a little girl than to a grown-up.
And KFC.
So the same thing happened to us. My dear partner in crime, Dr. Katafuchi, and myself. We went from one day to the other, talking about it on one day, making a plan. What do you think is going to happen? And before the end of the day, we decided, actually, we closed our office a day earlier. We stopped, full stop. And from this sheer panic, denial, not understanding what happened in 2 weeks' time, in 3 weeks' time, that we have a real healthcare crisis that affects all of our personal life and not only the little girl's life. We went from shock to actionism. We thought, in the state of shock and disbelief, and in denial, that there most probably will be very minimal emergencies and that restaurants are closed, dentists are closed. So, I mean, there's a very direct connection. What do we need all of our PPEs for? We are going to be doing something good, and we're going to be donating everything, including all other supplies that our medical healthcare workers need, to our hospitals. And we were not the only one. We live in an absolutely amazing state, in an absolutely amazing neighborhood with wonderful dentist colleagues that took the time and engage themselves personally to collect and to drive to the hospitals and to the healthcare workers, to our medical teams, all of the PPEs that they did not have as first-line defenders. Thank you again to all of the healthcare workers, the medical teams, and the nurses. Without you, we would be lost. Now, what is interesting to me, and I have been thinking about it over the last weeks, the world around us changed. And all of a sudden, words like, we're all in it together, nothing is going to be as it was, and the new normal started to swirl around. What was really happening with us and what was really happening around us? I don't know why it crossed my mind, but Dr. Kübler-Ross was a psychologist. She had passed away in 5-6 years ago, wrote a book about the 5 stages of grief, the curve of change, that really fit our current scenario. And this is the Kübler-Ross change curve that later on was modified. I find this very interesting because it shows the time of emotional healing. It shows the time and the emotions and the actions in a very interesting display. The first thing that happens is we're in shock. Everything changes around us. For the little girl, the restaurant's closed. For us, our life closed. Everything that we loved, that we knew, that we used to, disappeared. Everything. The schools closed. The kids came home. The kids stayed home. Daycares closed. Little kids were home. Everything changed over 24 hours. And we did not have the time, did not have the space and room to cope with it. It is time that we stop, and it's time that we look at it. So around on the right-hand side of this diagram, you will be seeing the correlated action steps to the individual phases of the curve, the change curve. I don't know about you, but I certainly have visited and stayed for a fair amount of time on all of the individual spots and phases of this curve, and I keep going back to individual ones. It is a constant movement. It does not go in a linear level. It goes back and forth, and it can change momentarily. In the shock phase, and let's move it forward, we are in disbelief. We don't understand what is happening around us. We move on through the frustration, recognizing that things are going to be different. Then we go through depression, low mood, lack of energy. Then we start to recognize and realize that things are changing, and we kind of get a little friendlier with the new situation. And then we start to adopt, and we start to work on it. In the initial shock phase, what is very important, and I'm speaking to us as leaders and as team leaders and leaders in life, it does not need to be doctors. It's important to give a goal and a direction to people. We all love to know where we stand. We all like to see that. We like to see goal timelines. We like to see responsibilities. We like to see certain things that make us feel that we are. Second phase, we're frustrated. The action step for that is to maximize communication. And sometimes it doesn't mean that we have to talk, which for me is, of course, a very active act. But it also means just to listen. And at this stage, I would really like to thank the AGD for what they have done, not only for their members, but for the entire dental community. And I'm not sure if it is only local or not, and it would be wonderful if it wasn't. Because they gave us something, goals, time, responsibility, kept our curiosity, kept our interest alive in what we do. They provoked and invited communication. Thank you very much. ADD Washington, Dr. Hess, Dr. Hayamoto, Albert Bertoli, you have worked endlessly. The third phase, the experiment, initial engagement with the new situation. What do we need there? We need to include people around us, and we need to share as much as we can about the plan, about what we know that we can. We want to motivate. We require now new learned skills. We require new capabilities from ourselves and the people. Now, when people are in depression during that time, we can't push the performance or feedback, but we can provide immediate motivation because it's very simple. The person's presence, your teammates, your friends, your neighbor's presence has value. And show optimism that things will be okay. The fourth phase is develop capabilities. No slack time here. Allow for people to practice the new skills. We need to be a change agent. We need to enable it. In the experimental change, we cannot back off at this point. We have to keep focused and we have to keep coaching. Maximizing performance feedback, not only positive, but also critical. We need to move quickly to get into the productive performance feedback into the last phase. And this is the phase where it becomes fascinating, it becomes interesting, it becomes like we are in charge of our life again, and we are building something and we are creating something. We feel ourselves again. This is the phase of sharing knowledge. It makes it independent from you. You don't need to be the coach and the consult. You encourage teams to work with each other. We encourage and learn from each other. And this is when we go really into the change and into the growth. And that does not mean it's easy, and it does not mean that we don't fall back into certain phases on this curve. Now I have put this little circle on the curve in my assessment. We are somewhere on the ascending branch. Of course, there's a standard deviation. That's why it's a little bit longer. There's good days and bad days, but we are moving up. And this really is what then brought it together for me, because the change of curve is that we all feel, and this sentence and the word came up, that we're all in it together. The drive and the need to communicate, to recognize, to see, to fix, to share, to be angry was there. And not only locally, but globally. Now, we have to ask ourselves, have we actively done this with our teams? Have we done this with our patients? Have we done this with our colleagues and peers? If not, we might want to consider that. Now everybody is going through the same, and everybody is going through the same at their own pace. We all have a different pace. And the biology keeps its own place. Some of the patients that go through this change, that feel that the carpet is pulled away underneath them, that is a German saying, my apology if it doesn't make any sense in English, still experience pain, still need a doctor, and still need to do something. Now, what Maya Angelou did, and not really a person that quotes a lot of people, but I ran across this, and I have been overusing my cell phone during this time of not being able to work as a periodontist. So I saw this quote somewhere, and I am not on social networking. So most probably one of my dear friends sent it to me. If you don't like something, change it. If you can change it, change your attitude. It's summarized beautifully. We did not ask for COVID. We did not ask for the economic crisis. We did not ask for everything to be shut down, especially the childcare centers and schools. We did not ask for the university to be shut down. We did not ask for any of that, but it is here nonetheless. We can choose on how we look at this special time and how we want to be part of the change that will come. We need to choose if we want to be the part of the change that we want to see. How do we want to have the new tomorrow? And how would you like to build your own house that you like to live in? I look at this time, of course, as a challenging and a hard time. But I also look at this as a renewal, as an immense opportunity to recreate what we always wanted, but we never could because we always, at least I always had enough excuses and other things that are more important. So let's take a look. Here it goes out the window, my dear colleague and partner in crime. Dr. Kadafuchi, we were wrong. Emergencies started to roll in, not in the first week, second week. I did a little survey with all of our friends and general dentists. When you work closely together, you become friends with the dentist, and asked them if they could share some of their cases that they see, because I was curious to see what kind of an emergency do we see when there's a pandemic in the world. And here is a case. And this is not a case that is unknown to most probably all of you out there. Patient that was treatment planned and diagnosed for it 2 years ago, and for whatever reason didn't follow up on the treatment. Now, in the lockdown, the tooth cracks into the pulp, requiring an endodontic treatment, which was all completed in one appointment, which is really an amazing, I would call it an amazing translation of an adaptation and the change by Dr. Butaro's office, 5 Dental Center, bringing the patient coordinated chapeau, as we say in French, to the team that could coordinate the patient and get all of the information so that this treatment could be provided in one session. A, to have it the most predictable treatment in dentistry, the most predictable outcome for the tooth, and B, we all have, we have a shortage of PPEs, and we must be careful and considerate on how we use it. So there's twofold. There is the best for the patient and how we do manage what we have at hand in the best way, because A, we don't have any when we're out of it. B, we also have to have an economic perspective on our business. Let's see what else is there. Oh, there it is. Decay running into the pulp, requiring treatment. Was also performed by Dr. Mitchell in one session. Here we have an infection on tooth number 16, and a deep caries, again, approaching the pulp on number 14. Number 16 was extracted and the treatment was performed and completed again in the same session on tooth number 14. Now, we as periodontists, of course, are a little bit more boring. We follow the rule in the book sometimes a little too much. So we did not take any photographs during this time. So I can share some of the cases with you because we are unfortunately sometimes very academic nerds. What did we see? We saw infections, mostly infections, fractures, either tooth or implant temporary. We saw apical periodontitis, which often is the result of a fracture. Peri-implantitis, infection around implants. Acute periodontitis, and I will stay with the old definition at this point because I have not met too many non-periodontists that are enamored with the new. With pain, how do we treat them? Can we treat them all with antibiotics? Heck, no. We must keep in mind that these patients will continue to live. And we must keep in mind that we are dentists and we cannot just do palliative treatment. We must treat the symptoms. More. Fractured teeth, Dr. Rhodes, Dr. Kelsey Rhodes, infections, spatial infections, extractions, and the management of that. What would happen if if we as dentists wouldn't be there and to do that during this time? And I don't know if you had the same experience, but to me it seems like there was pretty much the same exponential curve as COVID started to rise. In the same curve, the teeth started to fracture after we were on a lockdown. It seemed to have changed. Patients are stressed. You clench your teeth, you grind your teeth, and of course, Murphy's Law hits as well. And then there's these patients. Obviously no stranger to dentistry, but a lot of infection and a lot of pain on areas where the bone is not present, where infection is present. Caries infection is present, and the restoration is broken off and away. And then the 85-year-old gentleman that has an active infection of the gingival tissue. Well, clearly, this gentleman has to be scheduled back after the reopening and have the infection, the acute periodontitis, treated with non-surgical therapy. Well, and how many of us who think that recessions don't ever hurt? This is a patient of Dr. Powell, and this is the beginning of teledentistry. The selfies of gum tissue and teeth and cheeks and retromolar areas have been floating back and forth between specialists, oral surgeons, periodontists, general dentists. On the left, you see the acuteness of it. She was in pain. Dr. Powell saw her, did non-surgical treatment, cleaned up the area, deplaqued the area. It felt better. I thought, great job, very good. You did not create aerosol, we're all good. 2 weeks later, the next picture comes. She's very concerned now to lose the tooth, and she is still in discomfort, not as acutely as she was, but still in discomfort. And then, disclaimer, I have to say, this is the finger of the patient, an 85-year-old retired physician. And she self-diagnosed with a spatial infection around the canine area because she had swelling. She came in her first selfie ever. Kudos to her. And we had to treat her. So what do we do? What do we do with all of these teeth that break? What do we do with the patients that need care? What do we do? And how do we want to position ourselves in this time and in this situation? There has been, and I have heard, so many things going around, so many misinformation, wrong interpretation, a lot of free-floating fear. And we all are anxious. We all don't have all the information, but we do have information, and we do have knowledge about a lot of things. We have to remember that we have been trained as dental professionals, some as medical and dental professionals, and some may have a history degree in addition to that, to remember that there were generations before us that did the same. And remember that we have had viruses, bacteria, crises ever since we can look back. How did we survive all of that? How did we manage it, and how did the professions manage that? It's by thinking and concentrating on what we know, evaluating the facts, understanding the risks, understanding that bacteria, viruses, all of that can change their shape. It's like a woman coloring the hair. Sometimes you just don't recognize them. They have to do a second look, and it takes its time. So what do we really want to be? Do we want to be a supervised COVID-19 neglect doctor? Do we want to just give the patients palliative treatment and antibiotic resistance? Or do we want to think of them as, and ourselves, we're dentists, periodontists, orthodontists, oral surgeons, prosthodontists, we're not going anywhere. Patients will need us, and we are here, and we're not going anywhere. And we do need the patients as well. We have worked hard for it, and we have been trained, very highly trained. I'm surprised to see how often we give in and fall for some hype. I just get excerpts forwarded from my friends. Again, I am not on social networking. I'm working up my courage to get there, but I'm not there yet. What stories are being circulated without any research and without any foundation? We have to think about that the dentists and doctors that took care of us, they had a lot of epidemics as well. Myself, I remember being a medical school student and on an intensive care unit ward in Germany. And the first HIV patient came in. Oh, because I was a student, I was not asked to work and to go into this patient's room. But I did. I said, I have to find out before I'm done with school. I must see if I can do it. Purely emotional. We didn't know anything about the HIV and AIDS. It was the early 80s. So in full hazmat suit, with extra garbage cans, I looked like I'm working with uranium, double door, complete negative pressure, everything. I walked into that room, and this young man sat there, double gloves, and I wanted to take the vitals. And I will never forget the first thought that I had when I went into this room, completely emotional. I didn't have a gas mask. My first thought was, I wonder if I get infected if I take this breath We knew it's bloodborne. Had no scientific basis. It was complete fear and no ratio. Well, I was in my first year of medical school, so I wasn't at the level where I could look at things a little bit differently. But I recognize I will never forget it. It came to the point that the next day I took off one glove because with 2 pairs of gloves, I could really not feel the pulse. And he asked me, can you feel anything? Let's not forget, we are highly trained medical professionals responsible for the diseases of the head and neck. We are responsible for the systemic health of our patients. Remember that. And remember that we've done this before. So we will be tackling this crisis also together. How? I've discovered my new love for Maya Angelou quotes. Do the best you can until you know better. Then when you know better, do better. So there's a lot of questions that we have and that has been forming, that are floating out, that are floating around on the market. The fear, the staff fear, hygienists, dental assistants, surgical assistant, doctors, associates. Where do we get the PPE? Can we reuse the mask? Is my workplace safe? Am I going to put my family at risk? What really is an emergency? Can I do this? Am I allowed to do it? Am I not allowed to do it? A lot of questions. And you know what? We'll try together to find answers to all of that. And we'll find answers by evaluating the scientific evidence that we have, by looking at the experience, and by looking at the interpretation of the law. And ultimately, after all of that, we must remember that we all took an oath. And we must act in line with the Hippocratic Oath. Do no harm. And treat the patient. So are we ready? Are we ready? This is really, these thoughts and these 8 weeks that feel more like 8 years brought me to this topic that I've never talked about. And while I was preparing this presentation, I was biting myself and said, it is so much easier to talk about dentistry. It is so much easier to talk about periodontics. It is so simple. It is logical. It is different. But stepping back and being in an area where you're not an expert and you have no experience, which I think right now is the perfect ground, because we all are somewhere or in the very beginning. It's a good time for us to remind ourselves who we are, where we want to go, and how we can get there, both personally and professionally. I'm hopeful that you will find or rediscover one or the other pearl for yourself and your practices. By us sharing our journey and evolution we took over the last 8 weeks. And I truly only believe science is only as good if it can be applied to a practical application in life. Throughout the rest of the webinar, I'll do my best to review some important facts that we have that have shaped some of the misinformation and opinion. I will share some tips and tricks that we, in collaboration with dentists or the specialists, have come up with, just sharing it in a not organized fashion. And I'm looking forward to continue with a collaborative platform and take us as a profession, as a value, and as a service to the community patients and the patients to where we want to go. So let's take a look at the little, at the party crasher, Corona, which is scientifically known as SARS-CoV-2, and who has been giving us the run of our lives over the last 8 weeks. What's so new and special about this virus? and in comparison to all others that we already know. Well, sometimes Charlie Brown says it best. Linus asks him, Charlie, what surprises you most about this coronavirus? And Charlie says, it has done what no woman has been able to do. Cancel out sports, shut down all bars, and keep men at home. Let's take a closer look at the superpower we're dealing with here. All right, a brief history excursion. Corona, SARS-CoV-2, traveled from China and expanded globally. These are the readings and the numbers from May 4th. The total confirmed cases at Johns Hopkins Research Center, and everybody can access these numbers online, is 3.5 million worldwide. The total death, 250. How does it look when you are in a lockdown in the country of origin? This is one of our dear co-workers, teammates, still considered a teammate because he still thinks of us every day, who has gone back to China to study dentistry. He was with us as a surgical assistant for many years, and I cannot decipher this, but he told me this is their weekly hall pass. I translated it to be that, to purchase groceries and necessary life supply in China. And that's about the only time you get out. This is how a lockdown looks in China. And this is a small video clip. Now, with a massive lockdown like this, where a rat doesn't even want to come out or is scared to come out, the mortality rate is about 3.6%, significantly lower reported, at least than any other country. It must just sound much scarier. And I must tell you, when I heard lockdown, I thought it's gonna be like this. Now, 2 months later, just look at the life there. It is starting to come back. And it feels different. It feels that people are more mindful, responsible, leaving space. And it feels, looking at these pictures, that there's some habit change that has happened. I love Asian food and I love Asian culture. And I have spent more time than anybody has ever allowed me in any Asian grocery store that I can be. And when I look at these stores, I miss the pushing and shoving, which usually happens when you're getting the vegetables. So this is where I come from. Now let's take a look at the United States. We have all these red dots there. We have 1.2, close to 1.2 million, death rate close to 70,000, a mortality rate of 6%. How does a lockdown look here? This is New York City. And this is one of the hardest hit cities that we have. People are moving out there and they are. So let's summarize. Ground zero, it's global. We must think globally. A reopening now is set for the 19th. And I have to say this because we had a lot of discussions on if it's 18th or 19th. The interpretation of the law by many specialist lawyers is that it is either at midnight of the 18th or the 19th, the practice opening. So let's take a close look and see what are the basic mechanisms. The pathogenesis, my apologies. The pathogenesis of COVID-19. Let's look at what tests we have. What are the infection risks? What do we do with PPE and the aerosol and aerosol management? How do we protect ourselves? How do we protect our patients? The disinfectants, oh my God, are they still good enough? You hear everything. And you hear a lot from the reps who take this opportunity and just tell you, you have to do it, otherwise you're gonna lose your license. Literally, it feels like that sometimes. So what's next? Well, attempting to connect science and practice, the what, why, and how to be clinically relevant and accumulate evolving information. It all goes back to the chain of infection, and it really is a very simple circle. We have the COVID there that goes into a source, in this case a human. We have to know how it gets transferred. There must be a door to walk through for the virus, and there must be somebody that lets the thief in. So let's talk about it. You know, in a dental setting, and this is where we are, in a dental setting, it is almost impossible not to have transmission of anything. By touch, by talking. But transmission does not really mean that it is an infection. We must get this out of our mind. Okay, and these are publications and science that is behind it. To get an infection, it depends on more than that, on the virulence, on how aggressive this virus is, and the frequency of exposure to the virus or to the pathogen. So the simple answer is no, the transmission does not make you ill. It did not make you ill. It does not make you ill yesterday. It did not make you ill yesterday, and it will not make you ill tomorrow or today. Now we should take a look and see what transmission modes are there. In the dental office, there's one: direct contact, hugging, touching. And I am as I said, I'm very multicultural. I think I've absorbed all of them. I'm a hugger. Direct contact, a transmission mode. And in this direct contact that can come from instruments, handpieces, viruses like herpes or the norovirus, as an example, that are present in dentistry, will be transferred. Blood contact. Hepatitis B, which still is between 37 to 39% of the infection. HIV and hepatitis B, I already said, I'm sorry. And dental water unit and aerosol have the largest group, as you can see, the blue group on the bottom. And there is a lot of viruses in there. Measles, rubella, influenza. Influenza, one of them that is really, really dangerous too. So we have risks of transmission. We must understand the risks. And it starts with who's the most vulnerable. Okay. Now, what we have learned is that every age group gets infected. That there's not really a way for any age group to say who is going to have severe syndromes or die and who not. We know, however, that when older people get infected, and they're usually a lower number, that their mortality rate is high. And that is mainly due to the fact that they have pre-existing conditions, they're older. They don't leave the house so that they don't have that infection risk, of course. That's why the number is lower. And the pre-existing conditions. How do these how does the transmission take place? Now we know that it can take place through droplets. And in the scientific brief March, just the end of March, from the World Health Organization. They redefined the droplets, respiratory droplets and droplet nuclei. I am worried my German accent is going to come out a little bit. It starts with a Latin every time. Respiratory droplets are big fat particles, relatively speaking. They're 5 to 10, and some of them are even bigger in diameter. The infection occurs through the mouth, nose, and eyes. And it happens in close contact, so you have to be close to each other, 3 feet or 1 meter. The droplet nuclei are the smaller particles. They're smaller than 5 micron. They're airborne. They fly and they linger a little bit in air, and they travel more than 1 meter. So what do we know so far? We do have 2 different modes of transmission. The transmission is not an infection. It needs to enter the host and inoculate it. It needs to have a certain virulence, and it needs to have a repetition to cause an infection. We need the virus to, I already said that. So what do? We need to protect the port of entry. We know the viruses mutate. They change the efficacy of the vaccines. Now let's take a look at the mechanism of the disease, the pathogenesis of SARS-CoV-2, and who this new bug is. This new virus is that has been pestering us a little bit. It is an RNA virus, and we actually know this RNA virus for some time. There's, including SARS-CoV-2, now about 7 strains of them. 4 of them cause mild syndromes of the flu, common cold syndrome. SARS-CoV-1, which was the epidemic of 2002, caused about 10% of mortality, and the Middle Eastern Respiratory Syndrome, MERS-CoV, which was in 2012, about 37% mortality. Okay. They are divided based on the genomic structure into 4 subgroups: alpha, beta, gamma, delta. COVID-19, corona, or SARS-CoV-2 is a beta RNA virus. Okay. How does it get into our body? It attaches to mucous membranes. It enters through the mouth, nose, eyes, and it enters our respiratory tract. It's a small virus. It is 125 nanometer, and it affects the lungs, heart, pharynx. It affects all of the organs, basically the whole body once it enters. And it elicits a very, very radical and a very hefty immune and inflammatory response. It would take too far to get into that. Well, these Frenchies are always very interesting. There's always unexpected support that we can find. Sometimes not enough evidence. And this is a very nice example to see that. Coronavirus. France drastically limits the sale of nicotine products. I'm reading this, I'm like, what is going on there? Well, what is this based on? It is based on hypothesis. It is based on a hypothesis, and as we go back into this, it takes us a little bit further. This coronavirus has little spikes, these little corona there, and it attaches to the ACE2 receptors, which are very, very prominent in lungs. Lung pathology and lung diseases very often. So as this coronavirus attaches to that, it enters, opens up the door, and enters the host, enters the body. Now, in this physiological explanation, they said, listen, smokers have much less ACE2 receptors. They're occupied. Therefore, we conclude, this is not proven yet, we conclude that the risk of infection with SARS-CoV-2 will be less. So guess what the French did? They all ran out and they all started to buy cigarettes, and we might see an increase, epidemiologically, it would be very interesting, to see an increase in respiratory diseases or cancer, lung cancer. So the French government says we can't trade one evil for the other, so you can't buy more than one carton. All right, the mode of transmission. Excuse me for 1 second. Where is this? Something dinging here. Droplet aerosol transmission and the airborne transmission as the droplet nuclei, as we said. Now, why? What is the scientific consensus today? The consensus is that most of the transmissions will travel via respiratory secretion. Will travel through large respiratory droplets. And they don't really travel through the aerosol. These respiratory droplets are heavy, and they're kind of like a water squirt gun. They don't travel that far. Instead, they fall down to the air and onto the ground. So they will not travel more than 6 weeks. The problem starts when they become airborne and aerosolized. That is a very different one. So this is a very interesting and a very important study on how we practice. This is, again, a lot of these studies go back to the centers in China, Wuhan centers that treated the first wave of the patients, and they have the first data of the patient population. They found in this study that, looking for SARS-CoV-2, that the virus is everywhere when you have an infected patient. And these are, again, as I said, the corona patients that are treated for the disease in a hospital in China. And samples were taken from the air and surface. They looked at the intensive care unit and into the ward. And what they found is viruses everywhere. They have more in the intensive care unit because, of course, the symptoms are more extreme. So there is a dose dependence that goes on. The staff was not always in PPP. The staff, once they knew about the presence of this virus, and they used the PPE, cap, mask, gown, goggles, shoe covers, no one got infected. They did detect some nucleic acid, but they could not say if these were alive and infective. Again, the World Health Organization, in their scientific brief, states there is no evidence today for the airborne transmission of SARS-CoV-2 virus. Picture out of China that was taken at the time of the height of the epidemic. I should call it, it was an epidemic when it was in China. The dental care on the patient. I actually thought it's a positive patient. I had to confirm with our dear colleague, Shan Ru, in China, and he told me it is not a positive patient, it is a regular dental patient. And now let's take a look on how doctors and healthcare providers practice here. Now, here's everything perfect. Hat, mask, glass, with side shield, gown, and the treatment of a patient. Now, this is not a positive patient. This is a regular patient. How much easier our life would be if we had tests and tests available. Well, they are not available readily to dentists yet. I hope that we can get them for us because we truly need them for triage purposes and to mitigate the risk. There are 3 tests: molecular test, antigen test, antibody test. I'm going to skip over this in respect of the time. And we'll move on to what we have right now as a summary of where the standing of the test is. We can get tested for antibodies through a physician. We can use the University of Washington lab in the near future. If we have antibodies with a serological test, we will have an increased resistance to the infection. With a virus, it will never be 100%. We don't have a point of care. There is no antibody test for dentists available to test our patients at the office. The regulations don't permit it at this time. The PCR test is the test that we can send the patients to through their healthcare provider. We have to have their healthcare provider, the medical doctor, refer them for a saliva and nasal pharyngeal swab for the PCR test to see an early infection. We have to keep in mind that often the results might be negative when patients actually are silent carriers and are positive. So what is very, very important for any infectious disease is the transmission rate, the R0 that defines it. And let's take a look what the R0 for different diseases is that we have today, okay? The common flu has an R0 of 1.3, COVID-19, 2 to 3, measles, 15 to 18 R0. It's very interesting. Why is it like that? Why is it? The R0 just means how many people you can infect with one person. So one person with measles can infect up to 18. The common flu, 1.5 people. COVID, 2 to 3. Why? The reason lies between that we have vaccines. We have vaccines for the common flu and we have vaccines for measles. Now, a lot of people, especially in Germany, choose not to vaccinate their children for measles, which I think is a large risk personally. And the R0 of the flu is down because of that. The influenza virus is a very, very contagious virus. So either it is your own immunity or an acquired immunity that we have. The global leaders in the world came back together and they have given another 7.4 billion available to secure in solidarity the development of a vaccine, which is wonderful. Now, why is it so hard to get a vaccine? A little bit science behind it. The mutation of a virus is 2 or more strains of a virus come together, they form a new subtype and a new strain. Now, it's like me changing my wardrobe and putting my scarf this way. Most of me is still me, but some of my surface characteristics may be different. So if I have a vaccine, what happens? Part of it will be active against the antigens that it recognizes. There's another factor with viruses that they can get super infected. And this super infection can make them become less susceptible to the the host immune response and also the drugs. The dose, the virus is a dose dependent. Yes, we have studies to support that. We need a certain amount of virus to cause an effect and an immune effect in the soon-to-be host. This is the process that we call inoculation. And if we give the right amount, it happens. If we give too much, you develop the symptoms, and worst case scenario, even worse. So what do we know here from the coronavirus? And that's on the wrong place. Okay. So what does it mean for our front offices and office teams? In order to protect ourselves from the virus, from the transmission of the virus, we have put up guard. This is a plexiglass guard that is not visible. It protects the front office from the patients. Signages are kept up and touchless dispensers are displayed. The virus, we had this, gets into the host through the mucous membranes. So the importance of the PPE, when to wear it, where to wear it, and what to wear is very important. It covers the port of entry, eyes, potentially, mouth, nose, and I would like to get through these different pictures of it. The first one is, I did take a selfie on a surgical day, and it was in the COVID time. It was an emergency patient. So I have an N95 instead of a level 3 mask on. That is the only difference for us. I would assume I speak for other surgeons too, that we experience at this point. These are the dentists that are taking our course in Germany, the same thing. Gown, mask, nicely over, loops are over the mask. The gloves are covering the sleeves of the gowns, and the hands are held up to decrease any contamination. Now, what do people come up? The goal is to protect it. Now, there is a lot of, the world is a colorful place for people that need to lip read. We need to live with the virus. The virus is not going anywhere. How do we communicate with each other? So some genius came up with the idea to put a little window in the mask. Love that idea. Then I have a dear friend and colleague, Dr. Powell, share with me a custom-made mask because of the shortages that are there. It is, I think, printed to mold it to fit the individual's face. And I understand that Dr. Knight did that, and he is a genius in that area too. It's amazing ideas that he comes up, how to transfer a regular level 3 mask to adapt it closer around the jawbone here to decrease the airflow in that area. Kudos, chapeau. These are PPE, how it should be worn with a face shield. When do we wear it? Based on the evidence that we have and not knowing the carrier, we need to wear this when we have aerosol producing procedures. We definitely need to wear the face shield, the gown, the cap, the glove, and in a positive patient or a patient that has tested positive. The question that often comes up, what do we do? And I have heard that from dentists, when I have my hygiene exam. We don't know if we're gonna run the same schedule, but what if I have to leave the operatory? Do I have to take everything off? And here we have to distinguish, and I'm gonna make a quick pit stop to say, it is case by case. If you have a positive patient and you are in an aerosol producing procedure, I take it off. Hang it on a hook inside of the operatory, doffing inside of the operatory, leave it on a hook inside of the operatory, go out, wash your hands, don again, put the new attire on, and walk into the next operatory. You can go back and do the same thing upon your return. If it is not an infected patient or somebody that is not suspected of a past infection, I would not, and no aerosol producing procedure was done, the gown can be kept on. Remove, of course, the gloves. Remove, the gown can be on. And if a face shield is there and it is not soiled and it is not wet and it is not soiled, which it is not when you don't have aerosol producing procedure, then you, I personally would wipe it with 1.5% superoxide and walk out. This is a different example that I got sent by some of my colleagues, going the other extreme to the point, I mean, very creative and very color coordinated, I can see, of not recognition. And then this is the French model again. You either put so much into the outfit, and if you don't have anything, then you have minimal outfits. The French don't have any PPO, and this is the way that the French dentists protest for their protective gear. This is a movie that I took from the internet. We have a shortage of supply, and I wanted to play that with you because this is a question that I have, and I had it myself too, come up many times. How?
Hi, I'm your Minou Van Dyken,
Minimum.
MD. I'm a surgeon by trade, but my true passion is helping people just like you obtain and maintain optimum health. We've made videos on this channel before about why wearing a mask can be beneficial in preventing the spread of COVID-19. And we even posted a video on how to make your own high-quality filter mask. This mask that we came up with is modeled after an N95, and it has very similar components. The links for these videos are in the description below. But what we've not really talked about yet, though, is how to clean and disinfect these masks. Ideally, an N95 or similar respirator mask is designed to be worn only once. It should then be discarded. That's a no-brainer, and that's what we did as health professionals pre-COVID. Now, there's a global shortage of masks. With such a shortage, hospitals around the world are looking for ways to be able to reuse these masks. They're forced to find ways to decontaminate the masks and reuse them. We just can't throw these masks away after one use like we used to. So, how can we decontaminate these masks and still keep them safe and working properly? 3M, one of the main U.S. manufacturers of N95s, has published a white paper in which they list 4 criteria that must be met in order for their masks to be reused. 1, to inactivate SARS-CoV-2, the virus that causes COVID-19. Number 2, not damage the respirator's filtration. Number 3, not affect the respirator fit. Number 4, be safe for the person wearing the respirator. In other words, it can't have any harmful off-gassing as a result of the treatment. 3M is very clear in that they do not recommend reuse or decontamination of their masks, stating that no method achieves all these goals. That being said, though, we're in a pandemic and we have to make do. So, what's the best method of decontaminating our N95? What if it's our one and only N95 we have to reuse over and over and over again? Well, let's back up and take a few...
Oh, sorry. What did I do?
Hi, I'm your Minou Van Dyken, MD. I'm a surgeon by trade.
With it.
What's that?
You messed around, but you must have hit something on your keyboard. You can just slide the bar at the bottom there, get her back to where you want to be.
Optimum health. We've made videos on this channel before about why wearing a mask can be beneficial in preventing the spread of COVID-19. And we even posted a video on how to make your own high-quality filter mask. This mask that we came up with is modeled after an N95, and it has very similar components. The links for these videos are in the description below. But what we've not really talked about yet, though, is how to clean and disinfect these masks. Ideally, an N95 or similar respirator mask is designed to be worn only once. It should then be discarded. That's a no-brainer, and that's what we did as health professionals pre-COVID. Now, there's a global shortage of masks. With such a shortage, hospitals around the world are looking for ways to be able to reuse these masks. They're forced to find ways to decontaminate the masks and reuse them. We just can't throw these masks away after one use like we used to. So how can we decontaminate these masks and still keep them safe and working properly? 3M, one of the main U.S. manufacturers of N95s, has published a white paper in which they list 4 criteria that must be met in order for their masks to be reused. 1, to inactivate SARS-CoV-2, the virus that causes COVID-19. Number 2, not damage the respirator's filtration. Number 3, not affect the respirator.
Uh-oh.
Okay, well, we'll post the link to that video over in the chat there.
Thank you.
It's really simple to get to that video, and unfortunately, you could try starting it one more time and using the slider at the bottom, but I don't think you have the full video embedded in your presentation.
Yeah. Maybe we can do it at the end. I don't want to stay over time. Now,
Okay, at the end, what I will do is I'll bring it up on my side, and I will play that straight off YouTube to
Yes.
the end on how to reuse the N95s there for everyone.
So what I'm going to carry on very quickly through this because we started a little bit late, so I actually have to pace up a little, and I may go a little faster through some of the sections. We have, during the 8 weeks, we have started to create some educational training videos, and that is the entire team for the purpose of staff training, patient education, bringing staff and patients closer together, and creating comfort and confidence, and most importantly, cross-training. We have amazing, everybody does something that they usually don't do, and there's no better learning experience. All of these, if you want any of them, are available. I'll share all of them with you. I'm not going to play any of them, except maybe for this one. How to store a mask for later. This sounds a little bit like saving leftovers, and it is with a Tupperware. So this is about a 20-second video, and it might be helpful if you have 2 N95 masks and you want to make 6 uses out of it. Dr. Katafuchi is demonstrating this.
I'm gonna use this box. Go here, open it up, and I'm gonna go like this. Go like that. Put this KN95.
So you never touch the mask, ever touch the mask. The moment you touch the mask,
And
this is the surface
So
of the mask is where the virus, the bacteria, the pathogens sit. Never, ever watch it. It is the loops that are watched, and the very clever part of this is that the loops hang out of the Tupperware. So that is something that is nice. We are creating very special, we call them Corona soaps, because for whatever reason, we think it sounds a little bit more like happy hour when you have to update all of your systems and workflows. We have SOPs for new patient interim examination workflow. Dr. Kitafuji has done a beautiful job here in creating a beautiful aesthetic ambiance as well. He and we love to have flows, not reading, but a diagrammatic expression of what needs to be done. And we have to review them. We have to review the flows that we think are gonna fly once we're back in practice, because it depends on so many factors on how the systems, the new COVID systems and standard operation procedure are going to be. I'm gonna share a few little tidbits and tricks there that are easy to do and applicable in your practice. I don't call them updated morning huddles. I call them updated morning huddles because the focus is on the infectious disease. The focus is on COVID-19. So we must come and approach this from that angle. We must think as a host of high risk. What easier way for me is there to say, what would I expect as a patient? I want to see that my doctor's office, the staff, the healthcare worker, everybody has been screened, that they have their mind in the game and that they think about this and that they think about my health and my well-being. So we made little stickers that you can print every morning as part of your morning huddle. Jan, date, I was screened. And what are the screening questions? The screening questions, we go at this at the end. I'm pretty sure that all of you are familiar with that, and you have that. A lot of the procedures and operating procedures that we're doing are going to become online. Virtual consultation, teleconsultation. Why? To minimize the risk of exposure for potential carriers and patients. And integration of teledentistry. I learned a lot of that from Dr. Knight, an amazing orthodontist that we happen to have across the street from us, and he is a tech guru and an outstanding orthodontist. He hooked me on DoxyMe, which is a medical software utilized in teledentistry, and it works unbelievable. I am very, very new to the application of that, and I cannot tell you very much to it because I started to integrate it when we were closed. Then Tulu is another app. It is not proprietary with a spelling mistake. Patients can look up teledentist, and of course, it will also show teledentist in your vicinity. DoxyMe is just you. So let's take a quick look at the research that we have on aerosol, which is what carries the virus, which is what is dangerous for us as dentists if the virus floats around and lands somewhere and is alive. So there are some studies that are out there that have looked at it, and some of them have really wreaked up havoc. This is a laboratory study that actually looked at SARS-CoV-2, corona, the stability of it, of different surfaces in comparison with SARS-CoV-1. A lot of the recommendations, a lot of the numbers that we have is based on this study. It demonstrates that in this lab setting, viruses can float in the air and stay there. The surfaces with corona can be active with smear infection for days. What they also found is that actually the SARS-CoV-2 is less effective in staying in air than SARS-CoV-1. Very interesting finding. However, it is a lab study. Let's look at the clinic and see how this virus behaved in the air in the clinic. Again, this is a Wuhan study, and it is summarized in a scientific brief of the World Health, WHO. So excuse me, I take this back. This has been adopted by the World Health Organization, stand correction. And what they have said is that an airborne transmission, the airborne aerosol route, is not proven by evidence for SARS-CoV-2. So there is no evidence today that this airborne, this pathogen, this virus can travel and be transmitted airborne. The laboratory study, just to give you the hours, on stainless steel 72 hours, 24 hours on cardboard. Copper surfaces there is 4 or 9 hours. and in aerosol up to 3 hours. But again, it is a laboratory study. The interesting part starts when we look at the clinical studies. Again, Wuhan study, and it looked at breathing. These are infected SARS-CoV-2 corona patients that are positive, hospitalized in a ward in Wuhan, China. These patients, with or without mask, the study could not isolate and find airborne virus 10 centimeter, which is about 4 inches, 4 to 5 inches in front of their mouth by the mere fact of them breathing. And that is what causes the aerosol. So that is really what is important and interesting to us. This is the route of aerosol, no matter if they had a mask on or mask off, 10 centimeter, this much. No virus found. As another study. They looked again in a hospital in China, in the intensive care unit and ward, at the virus distribution and the aerosol. Where do we find it? Okay. The virus is everywhere, but mostly they found it on the floor. And remember what we talked about, the droplet size and them being heavier? These most likely are droplets. The larger, heavier, that don't travel and don't stay in air. Okay? Fall down to the floor, you know. They found that shoes tracked the virus. No staff was infected with COVID-19. No evidence on presence of active virus in aerosol. All right, now let's see and take a look at the disinfectants that we have in our practice. We know that the virus, the likelihood of it traveling in air so far is pretty much zero. The evidence that we have does not support that. It travels in droplet form. That is what we know. Mainly falling on the floor and on surfaces. So let's take a look at surface disinfectant. In short, I don't want to go too much into it. I give it a thumbs up. All of the things that we have in the clinic work. Now, I am not an expert of all of the things that are out, but just recently, I happened to eavesdrop on a conversation of a dear colleague of mine who was ordering new disinfectants. And there is a new product out, which is called Optics, which is based on superoxide. It's an improved formula that can disinfect the surfaces in 1 minute. And also takes the tuberculosis virus, which is the standard, the golden standard in infection control, down faster. It inactivates, kills the virus in 1 minute. There's a review paper by the World Health Organization, which pretty much recommends that ethanol, alcohol, isoalcohol, glutaldehyd, formaldehyd, that is German, I know it, I cannot say these words in English. Sodium hypochlorite has a concentration of 0.2% and higher temperatures. This virus is temperature sensitive. We recommend superoxide, ethanol, glutaldehyd, formaldehyd, propidiodine, chlorhexidine is pretty much ineffective. The concentration of superoxide There is a debate out there. Some people, the studies have, Johnson says 1.5%, which is what we do here and what we use. Whoever tried superoxide does not taste very good. We have an amazing compound pharmacist next door to my practice in Tacoma, Union Pharmacy, compound pharmacy. And the owner, I spoke with her, and she gave us a very, very simple solution on how to make that ourselves at home. Don't buy it from a compound pharmacist. That's what she said, because they have to have some medical grade. Buy the Walmart bottle, 3%, dilute it with Listerine, 50-50, in a ratio of 50-50 for rinse for your patients. And you achieve two things with it. You extend the shelf life for 1 month to about 6 months, because the moment you open the bottle, it oxidizes, and Listerine is not water. So that will protect that. And it tastes significantly better. Little tidbit on the side. Disinfectant is very time sensitive. Just like they say, I told you not to use Clorox. Maybe you just sat in Clorox for a little too long. SARS-CoV-2 virus. What temperature is it dead? The temperature, that they call it the thermal inactivation, or the denaturalization of the protein, is at 56 degrees Celsius. This is when the virus is high and dry. The moment the virus is submerged in some other protein solution, what is that? It's important to clean and pre-clean the instrument. It will require a higher temperature, in this case 60 degrees Celsius, which is very close. So these are, for our standards in our sterilization rooms, very easily achievable temperatures. We have a very, very high standard in sterilization, and it is not a problem. We kill the bug. What we haven't talked about is how else we can kill the bug or dilute it, okay? We know that inoculation and infection is a sum and a summary of how many viruses are present and how aggressive they are. So if we can add ventilation to the whole mix, we will dilute it. Very similar to diluting a drink. So having, I don't know why I just said that, but it just came to mind. I think I forgot to make the disclaimer. I have ADD. All right. There are some very, very interesting historic historical findings, architectural findings, that old cultures, Chinese culture, Indian culture, Persian culture, built their hospitals over thousands of years outside by the principle of airflow, having circulating airflow engineers to circulate a draft that carries, just like the wind, a leaf or sailor, the virus into a certain direction out. And what they find, and these are not high-tech countries with high-tech equipment, no, it's just a nice breed like a house on the beach, that the transmission among humans, among the patient, is significantly decreased by having an added air ventilation, okay? This is all natural air. And they tested that, and they have data for chickenpox, they have data for smallpox, they have data for TB, measles, all of that is there. So if you think about what we said earlier, these are the cytomegaloviruses, the rubella viruses, the tuberculosis, all airborne viruses. So airflow has a positive effect to it, to the dilution of it. There's the natural airflow, and then there's the one that is a little bit more expensive, such as, example, surgically clean air that works with filters, HEPA filter, and it has UV light, and it has an ionizing element in it as well. I don't want to go too much into the technical part. We want to get a little faster through this. So the Ventilation has a positive effect, stability. We can kill the virus very easily. The droplet travels a short distance because it's the heavy, the spit, the saliva, the bigger droplets that fly out. It's not airborne, it's not the nuclei. Port of entry, mouth, nose, eyes. Attaches to the mucous membrane. Let's look at the aerosol and splatter in dentistry. Again, in the department of aerosol, there are two sources. Not every aerosol is infective. As a matter of fact, it is often a splatter. It's a spray of water that comes out of an instrument. It becomes infective or pathogenic when it touches a infectious material, the tooth. Now, there are studies that were conducted after SARS-1, the little brother and sister of SARS-CoV-2, in 2004 by Stephen Harrell. And he actually looked at this predecessor and family member, SARS-CoV-1, and the presence in aerosol, and how much aerosol actually you can capture with a high vacuum evacuator. And he did this actually very clever. I think it's simple and brilliant. He used some dye to stain a grid paper and developed the number, so that you don't say it just visual like that, by having a splatter, colored splatter with erythrosine on a grid paper. 90 to 93% reduced aerosol with the use and the proper use of HVE. So what is very important, and we have included that in our retraining and resharpening protocol, which we also have and are implementing, the technique, the proper utilization of every instrument that we have, starting with the suction, where to be in order to maximize the suction, in order to maximize the benefits. Barrier, protective mask, glove, eye protection. Of course, we talked about all of that. And one other way on how we can reduce the aerosol is we as dentists should make the difference. I can talk about myself. Sometimes I'm a little bit too impatient and I start to turn on my handpiece before the HVE is in the mouth. I have committed to change that. I want to have the HVE on first in order to reduce the aerosol and suck up the saliva, and then start to produce aerosol, because that makes a difference. Pre-surgical rinse with 1.5% superoxide and Listerine to reduce the viral load in the mouth. That is by Dr. Davidson, and it reduces the biofilm, the viral load. What I like to do in addition to that, once the superoxide is there, a secondary rinse with pre-surgical rinse with chlorhexidine in order to get the oral microbiota as well. All right, we have that. A little excursion on, again, the survey, just like the cases that we're seeing on HVE options. Okay, there is a lot out in the market and you can spend your retirement fortune on it. Or you can train and plan and mitigate the risks. And looking at what is out in the market, what the patient can tolerate and will tolerate, and what your team members, your hygienist, feel strong and comfortable with working, because that is important as well. And these were kind of the top runners and favorites. And the Relief, which you see here, the Isolite, I have heard mixed reviews on that. And the New Bird with a mirror, the warm mirror, and one that doesn't fog. That is something that my hygienist wanted and is in love with, I hope. Thompson tips, which are the shorter tips. And then a very simple old school contraption, which is a cone that is attached to high-speed HVE. It costs like $20 or something like that. You attach it on it. The downside is that the patient has to hold it. My dear colleague, Dr. Eng, had sent that to my dear friend, Dr. Young, and she shared it with me. So we have multi-corner communication and exchanging great ideas. Thank you for sharing. This captures a lot of the aerosol, but you need to have 2 HV high vacuum lines. The dental devices that produce aerosol, ultrasonic, sonic scaler, number 1, air polishing, air water syringe, air turbine, handpiece preparation, and tooth preparation with air abrasion. Now, what is very interesting is to look at, excuse me, let's skip this. This is not that important. We already covered that. Surgical mask versus N95 mask. Is there a difference? The short answer, based on this study, and this study is a Canadian study, so I know that Dr. Hess will say there is no flaw in this, shows no difference. This is an influenza study, a highly infectious virus, as we know, for 1 year in Ontario. 23% of the nurses, they had a group of nurses that wore the N95 and the other one that wore the surgical mask, and the compliance was equal. And these nurses, 23% of them caught the bug, got influenza. No differences in the group. So the masks are comparable and there's no difference in their protection. Ten years later, they look at it again, and this time they look at the mask test, because masks protect us from aerosol, with respect to the coronavirus. Again, there's no difference in N95 and the surgical mask. The N95 and surgical mask, the coronavirus does not penetrate the surgical mask, based on communication, based on the studies that we have. As a matter of fact, and this is a very, very interesting finding, if we look at the data, and this is just for a split second, the periodontal is coming out again, the surgical mask protects against coronavirus, of course, but in comparison to the N95 mask, but it does not get the influenza. The N95 mask does not capture all of the influenza viruses. The surgical mask does capture coronavirus and influenza virus. Okay, so can you re-sterilize? Can you reuse N95? Yes. The system that is allowed and has been allowed by the National Institute of Allergy and Infectious Disease as an interim solution with vaporized hydrogen peroxide is the best, and you can do it up to 3 times. Okay. Now, a quick excursion into the reopening procedures of the office. We have a in progress movement. It's the evolution. We have the educational training that is available for everybody, but that is not the mask of it. I wish that we had this. The American Dental Association has done an amazing job in releasing a workflow. It makes it so simple. What the only challenge is to implement it and to create the accountability. To follow a checklist, to do it every single time, and to be accountable for it. It is an amazing document, very thorough, I'm in love with it. I wish I didn't do all of that work because frankly, I think this is much better, that I highly recommend that you request. A great, great asset. There it is, the ADA Return to Work Interim Guidance Toolkit. It was released end of April. And what our next steps are in the reopening of it is to really, we have this all in a bubble. We have accumulated all of the information and we have analyzed the science. So our hope and our vision is, our goal, what we stand for is, we want to provide and we want to continue to provide dentistry and dental treatment the way that we have, always have. The quality there, the commitment there will not change. We will continue to evaluate the risk. We will update our systems. We're looking forward to develop a platform, as I mentioned earlier, a platform that allows and supports collaboration, easy collaboration between all of us. There are so many great ideas out there, and we don't need to, what we love to do always, reinvent the wheel. So I have adopted the ADA protocol, and we are fusing them. We are creating the protocol that serves the needs of our patients, our community, the needs of the dentists that work with us the best. So those are the next steps that we are doing. And I'm just checking here the time, Dr. Hess. Where are we with the time?
It's 11:30, so we had allotted 2 hours, but we have some questions here, and I'd like to do a couple of things. Number one, if everybody can look in the Q&A and just upvote any questions you'd like the answers to. Number two, what we'll do after this webinar today, we're going to make a file and give Dr. Karbakhsch that file with all the Q&A, and we're going to have her come back on Tuesday afternoon next week for an update based on all those questions. Some of you have written some story problems, so I really can't get through those questions here today, but we'll try and hit a few. I want to remind you, next Tuesday, that's May 12th, Dr. Markus Trosch from Germany will be presenting a lecture on aerosols. A lot of things that Dr. Karbakhsch has shared today are from his lecture and references as well, back and forth. And so I think he does an excellent job of that because I know so many of our questions are aerosol related here. So to register for that, you can stay to the end. If we put the flyer up, again, you can use the QR code or go to www.washingtonagd.org. So, okay, let's start going through some questions. Remember to upvote the questions, and please don't answer somebody else's question or I won't see it. Can we clarify if hygiene services are legal due to CDC guidelines still saying only emergency services?
I am not a lawyer. As I said, my first disclaimer is German. So I can answer this as a German. Would you like me to answer this as a German?
Feel free to.
Okay. Disclaimer, talk to a legal advisor on that. But if I take the facts that we have, it depends on the severity of the infection. It depends on the underlying health condition of the patient. Let's say the patient has to undergo chemotherapy. Let's go, the patient has some underlying health problem, has uncontrolled diabetes, has rampant infection in the mouth. It is, in my opinion, a medical necessity, and for the very simple reason, the gums are a seal around the teeth. You have infection there, it's all this loose tissue. what happens if we don't have a functioning immune system, an immune ring around the tooth? There is no barrier from our immune system left. And it's an open highway for the 400 to 700 bacteria, and now the COVID guest, that possibly can have a very easy way into our system and cause systemically damage, have an effect, and cause infection in the mouth. So yes, absolutely. Evaluate your doctor that is there as a German speaking, again, not as a lawyer. You must document that right. You must have the reason right. And your doctor will be able to help you to diagnose it.
All righty. I think that's the Persian in you talking.
Was it
Not
Persian?
a short
Did I
German
get my
answer.
cultures crossed?
Yeah. Okay. Are initial fit testing for N95 masks required?
I could not hear you, Dr. Hess.
Are initial fit testing checks on N95 masks required?
Yeah. Yes.
Okay. Recommendations on using ultrasonics during hygiene appointments.
Yes. Here's how it goes. I would like to invite and encourage everybody to think about the treatment as a sequence, not as a task. I think that's Persian again. Sequence and not as a task. Don't take the task of ultrasonic out of the treatment goal and objective. First, you have to think about the chain of infection. Is your patient healthy? Has the patient been exposed? Is there risk of exposure? Can the patient be a silent carrier? You have to be the spy behind enemy lines of the COVID-19. You have to find out what the risk factors were, if this is a high or low risk patient. So ultrasonic is not really the issue here. It is your detective work that is the issue. So asking the right questions. Sometimes you're in contact with somebody. We don't have tracking devices, and I'm not sure how this will be going in the United States, that give you an alert when you're close to somebody that has either tested positive or negative or has been exposed. We don't have that. So ask the screening questions, follow the ADA guideline protocols, universal precaution, and if you have all of that in place, I don't see any problems using it.
Again, aerosols. Do we need to put in negative pressure rooms and expensive ventilation systems?
Okay, now the German came out. I think I did this. I think it's ridiculous, personally, for two reasons. A, we're not big hospitals. We are in no position to even economically afford it. I mean, that's just an impractical solution. Two, the cheap negative pressure rooms, because I looked into that, I must say, in the first week of it, are not, quality-wise, not good and are leaking. You cannot even keep the negative pressure in it. Number three, there are studies out there that have shown the presence, and Dr. Feng actually shared it, Dr. Hess, if you remember, on one of these wonderful webinars. Was it? I don't know. I get my webinars close. Maybe it wasn't the AGT, but he shared on a webinar that in negative pressure rooms, there was the presence of aerosol and pathogen to be found. So a negative pressure room does not save you from that either. What saves you is assessing the risk, asking the screening questions. And if you get the gut feeling that they don't tell you the full truth, or maybe a little hesitant because they really want to get their teeth cleaned because they have a date tonight or something like that, what I often do, I tell them, I said, listen, I need to know that, not because I want to put you are possibly COVID positive into your healthcare, into your chart. I don't want to make you feel guilty. It's not about creating an environment that is full of judgment, and I hope that came across in the first part of my presentation. It is an environment of acceptance. The world is a colorful place. I say, I need to know that as your doctor. It does not go into the chart. I need that information so that I can manage your health and your safety. And I will get your teeth clean. If this is what you do, I will pick a different method that serves the purpose.
Okay.
Does that answer?
Certainly. Is there any real evidence that shows COVID-19 is actually in the aerosols created by dental procedures?
There is, yes, but there's no evidence that they are alive. There's even a hypothesis out there that says, you know, you have EMS, the air polish, that just by the sheer mechanical power of it, you could denaturalize and damage the body and the integrity of a virus. But studies are not there yet.
Okay, there's questions on how many times N95 masks can be reused.
3 times.
Okay, and then let's, I guess we're essentially out of time. I'm sorry. What we'll do is gather up all these questions and we'll put them together and we'll boil them down for Tuesday afternoon. Just a reminder that you may want to look at the webinars by Terry Harris over the last couple of weeks that are on the YouTube channel, the Washington Academy of General Dentistry. There's questions about where to get PPE for those of you that are Seattle.
I can get you some, yes.
Seattle King County Dental Society members. In your members area, I've been informed that Dr. Ogata has put a list of suppliers there for you. So with that, I think what I'll do is I'll take over the screen sharing. I'm going to show the last part of that YouTube video that you were showing. And
Thank you very much. And please let me know if there's any questions. And if you like to have any of the documentation, anything. And
we will do that. We'll put that together for next Tuesday.
Perfect.
All righty. Thank you, Dr. Karbakhsch.
Thank you very much.
And let's just end.
Will make the mask last longer. However, heat with a specific humidity is better at deactivating SARS-CoV-2. Scientists looked at alcohol disinfection. So while treating with 70% ethanol has been shown to be 100% effective in inactivating the virus, the N95 mask integrity is impaired. The mask just doesn't filter as efficiently and it never fits the same again. It doesn't provide an adequate seal. There's a protocol called the Italian protocol where the mask is sprayed with 70% ethanol. The front of the mask is sprayed 10 times, the mask is then flipped and sprayed an additional 5 times on the interior. This protocol did prove effective. Currently though, 70% ethanol is very hard to find, and thus the protocol is not practical for the average person. So back to the protocol we suggest. It's been studied for multiple cycles and demonstrated that it works well with little to no degradation of mask quality. It can be used to sanitize your mask upwards of 10 to 20 times. So here's all the stuff you're going to need. First, a Ziploc container. You want a 1.25 quart size container. Second, a convection oven with no direct line of sight to any radiative heat sources which would cause potential damage to the mask. Third, a paper towel. Fourth, water. And fifth, an eyedropper. So here's what you're going to do. First, you're going to preheat your oven to 85 degrees Celsius, which is 185 degrees Fahrenheit. Then, you're going to place your mask inside the container face down. You're going to cut a 2.5 by 2.5 inch square of paper towel and place it in the container alongside the mask. You're going to drop 500 microliters, which is a half a milliliter or 10 drops of water onto the paper towel. This will provide the mask with the exact amount of humidity needed, which is about 60%. Then, you're going to place the lid on the container nice and tight. Place the container inside the preheated convection oven. Again, that's at 85 degrees Celsius or 185 degrees Fahrenheit. Next, you're going to let it disinfect or cook for 30 minutes. Because it actually takes time, though, to get the mask up to temperature, the total time in the oven will need to be at least 40 to 50 minutes. Then you're going to take it out, you're going to open the lid, and you're going to rotate the lid 45 degrees. What this does is it allows air to naturally flow around the mask and dry it out. You only have to do that for 5 minutes. After that, you are done. Your mask is safe for reuse. So there you have it. What we feel is the safest and most effective way to disinfect your N95 or homemade quality filter mask. Let us know in the comments below what you think of this video. Also, let us know if there's any topics you really would like to hear more about. Until next time, everyone, stay healthy.
All righty. Well, thank you for everybody that has joined us here today. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We don't have a lot of time here. I'll just click quickly through these flyers and get to Dr. Troelsch's flyer for next Tuesday. And you can get that QR code to get registered. This is an excellent presentation. You'll want to see it, and we'll have some other resources with that webinar next Tuesday as well. Sorry about that. This is set to automatically move. We're going to have to jump off this webinar here in just a couple of seconds to get prepared for Dr. Yassine. We'd like to thank our sponsors, Comet USA, Patterson Dental, University of Washington School of Dentistry CE Department, and the Canadian Academy of Restorative Dentistry and Prosthodontics. We appreciate your support, and we appreciate those sponsors' support for next week's webinars that we will be doing. Remember, on Monday, we're going to have suicide and opioid training available for our AGD participants out there. So thank you. Those links for those courses should go up here. They'll probably be on our website tomorrow sometime. Sorry, we're just having a tough time, Val and Dr. Hayamoto and I, keeping up with all this, but we'll do our best. So, alrighty, with that, I'm going to say thank you. And again, appreciate you joining us for the WAGD Stay Home, Stay Healthy CE series. And we'll see you at noon with Dr. Yassine. Thank you,
Dr. Hess.
Thank you, guys.
Thank you, everyone.